of young lady. She has it's a besting eye, and PRP was planned as in terms of prevention of bleeding. Anti-VEGF medication was injected. You can see the picture before, and 4 days after, she came with terrible tractional retinal detachment. This progression calls as a crunch syndrome. She was operated immediately, and there were central detachment, some clots of blood that was sticky to the retina. With bimanual manipulation, step by step, we tried to remove this tissue. It was impossible to make segmentation, so in-block technique was done, and the tissue was relieved by manual technique. But after some manipulation, the visuality was lost, and I created the iatrogenic break. This blood, I put TPA. It was first time when I put it intraoperatively. I put it just to liquefy this clot. Finally, several weeks after, she got the visual acuity 0.2. And there is a picture of her eye and OCT image. Silicone oil was removed 3 months later, and there was local tractional detachment with the iatrogenic break. So I decided to relieve this traction. After serial unsuccessful efforts, I decided to switch to more easy manipulation and went to posterior pole, removed membranes, and then again continue with the tractional component around the tear. Remove this dense tissue as much as possible, applied laser and air tamponade. Fortunately, now her visual acuity is 0.7. This is the picture, some points as a take-home message. Crunch syndrome is a serious adverse event associated with intravitreal anti-VEGF injection in patients with PDR, also in occlusive vein and ROP. In patients where anti-VEGF is used before a planned vitrectomy, it's very important to close monitoring for crunch symptoms. And it's important to inform the patient about mandatory monitoring following the surgery, the injection. Thank you for your attention, and thank you for inviting for this great conference.
Thank you, Dr. Tatiana, for raising the subject of crunch syndrome. Dr. Baha, there is a way that you can predict crunch syndrome in PDR. I mean, that you know that this case would go into such a syndrome. Is there a way? Or
it depends on the case of the before I'm injecting anti-VEGF, and I'm searching for what that was.
Okay, Dr. Moghazi?
Well, I think for this specific phenomena, I mean, those cases where you have thick sheets of fibrovascular proliferation over the macula, like you showed before the injection, these are most prone to those. The other cases that have some kind of peripheral proliferation and some traction, the traction can increase. But the crunch phenomena, we see only with those very heavy sheets in type 1 diabetic patients. And actually, it happens also with PRP sometimes, the crunch phenomenon.
PRP is a known phenomenon.
Yeah. So in those cases, we know, again, beforehand that those patients would most probably go into surgery. And of course, the anti-VEGF would help. I sometimes do it in the morning and operate in the afternoon. And this helps decrease the, the fibrovascular membrane thickness, the blood vessels, just for those few hours, and then go in.
Speaking of the crunch syndrome, Dr. Tariq, with the PRP, how would you space your sessions of PRP so as not to get the crunch syndrome?
I usually stage my PRP, and I usually use a yellow laser, which is pretty, a little bit more gentle on the retina compared to the green laser. And I always try to leave areas for future laser, because I am not a big believer in heavy laser. Sometimes I do my PRP FA guided, So I'll do the FA, and based on the areas of the ischemia non-perfusion or MV, then I'll target my PRP more heavily.
So you do like on 3 sessions spaced?
Yeah, even 2
So
or 3
it's a
sessions.
one session like every other day, every
Sometimes
week?
I alternate with the anti-VEGF injection. So, for example, I'll do a session of usually if I have a patient with a simple bleed, we start with anti-VEGF injection that will dry some of the bleed, and then add some PRP, and then so forth.
There was I think a paper in the past that you can do the whole PRP in one session, and this is safe. I remember this is an old. You do this in one session, and do you think this might increase the Crunch syndrome in certain cases, or you don't find any?
Well, again, you choose the case, but
The case.
I routinely do a PRP in one session using the multi-spot laser or the pattern laser. And I don't see it in patients who are not prone to the crunch, but in such a patient, I wouldn't do it.
Okay, Dr. Singh, what's your take on this?
I think he rightly said that if there are extensive neovascular complexes which are connecting with each other, those are all high risk cases. One option is to give half dose anti-VEGF also, if you are really worried,
Half
and
dose.
especially your
Excellent.
patient is not ready to get operated. But sometimes I have a question for all of you. Once in a while, we all have faced this. Sometimes I have a feeling we would have, once there is a crunch, we could have waited more, let the whole thing get more
Mature.
fibrotic.
To
Because
mature
anyway, now, it has, because you get those iatrogenic tears, you don't have a good feeling, although your result was excellent.
It was the only one seeing eye.
And there is a lot of bleeding, I think. So would you inject before?
I think the main cause of this crunch syndrome is the associated condition or systemic condition. It is not related to the PRP or not, or anti-VEGF or not. I think it is associated conditions.
Great. Would you use silicone oil, doctor, or gas for such cases? You mean silicone oil in a diabetic eye might invite more proliferation? Do you think so? Or
If you struggle with bleeding during the case, especially in these diabetic patients, sometimes the blood will come like thick and keep bleeding, even with anti-VEGF injections. I prefer to put a short term of silicone oil that will give me better visualization post-op, also better visualization for the patient. And then I will try to remove the silicone oil maybe within a month, and then I will switch them to air and add more
so
later.
short-term tamponade with silicone oil would help.
Yes.
Okay. Dr. Hussein has a comment. Yes.
It's okay. So rather than having the crunch syndrome, I think in this case, the most important thing that Tatiana showed that whenever you have iatrogenic break during the first surgery, don't leave any traction. When you are doing first surgery and you don't get any break, you can leave the traction at periphery. You can leave the traction at nasal retina. It doesn't harm. When macula doesn't have a traction, you have done the good surgery. But once you get any iatrogenic break, then you cannot leave traction on any part of the retina. Otherwise, it's going to fail the second surgery and third surgery. And second thing, regarding the crunch syndrome, it's not very much often. Nobody knows why in some patients happen and why it doesn't happen. Our school think that if you have a more vascular component, give the anti-VEGF 5 days before. If you have a more fibrous component, give the anti-VEGF 3 days before. It has logic and it has a base why to do it. So it's not like I want to give like 5 days before, I want to give 1 day before. It's not I want to give 7 days before. You should be logical. More fibrous tissue, less days you need anti-VEGF. More vascular tissue, you need more days to get it dry.
Okay.
So that's all.
Great. Thank you, Dr. Tatiana,
Thank you.
for such a wonderful presentation. So let's now, my friend Dr. Hussein Khaqan, he's talking about my dropped, I don't